Welcome, ladies and gentlemen. I'm Dr. Silva. Thank you for joining me for this talk on catatonia, a rare but fascinating psychiatric condition. Catatonia is a state of extreme unresponsiveness and immobility, classically. It's a neuropsychiatric condition, not only psychiatric, but often neurological in nature, and it's also seen in other medical conditions, for example, viral encephalitis. Although, as a psychiatrist, I don't consider encephalopathic states with known etiologies, with known causes, examples of catatonia. When psychiatrists speak of catatonia, we're referring to a functional syndrome that arises in the context of an acute, severe psychotic episode. Catatonia is a psychotic symptom. It indicates that the patient is out of touch with reality, likely paranoid or harboring some other delusional material, and possibly hallucinating in mood-congruent fashion. There are two kinds: a negativistic, mute, unresponsive type, which is what we classically think of when we say catatonia, featuring stupor. Stupor, which is defined as no psychomotor activity, the patient is largely immobile, frozen, and not actively relating to the environment. As well as a less recognized agitated excitatory type, which is often overlooked diagnostically, especially by inexperienced clinicians. The cardinal features of the former include negativism, immobility, mutism, and abnormal posturing. Negativism in catatonia is when the person resists or doesn't respond to instructions, questions, or other stimuli. This is the classic presentation, what trainees think of when we say catatonia. It most commonly manifests as not answering questions or looking at or otherwise engaging the examiner. But other examples include, for example, keeping food in the mouth and resisting chewing and swallowing. Catatonic patients often aren't eating or drinking, which over a period of days can render the situation an emergency. Severe sustained catatonia can be life-threatening. The catatonic individual might be seen standing silently in the day area. They're typically encountered in psychiatric inpatient settings, somewhat at attention, ignoring the examiner's questions and commands. They don't necessarily isolate. A catatonic individual is often out in the day area and will sometimes stand in the same place without moving for hours. Posturing in the context of catatonia can mean immobility and or rigidity, but it can also take the form of grimacing and stereotypies, stereotyped, repetitive, purposeless movements such as rocking back and forth, hand flapping, head nodding, finger tapping, or any number of behaviors. They're also often seen in autism spectrum disorders and in other individuals prone to tics and tic behavior, especially in situations of boredom or stress, situations which exacerbate tics. One type of rigid posturing is a phenomenon known as Gegenhalten, a German verb that means to hold against. Gegen, against, halten, to hold. It means to counteract, to resist, to oppose, or stand one's ground. In a medical context, it's a symptom neurologists see that involves involuntary resistance to passive movement. It appears automatic rather than willful, and it's interesting because the resistance to movement is not only proportional to the force applied, but also to how quickly the examiner attempts to move the patient's limb. So that if the examiner tries to gently move the arm, they might not elicit the reflex. But if the examiner is hasty or applies a lot of force, the patient resists the movement, holds the arm in place, and as the examiner begins to apply more force, they're met with a resistance of equal and equally mounting strength. The patient just automatically applies just enough resistance, just enough force to resist the movement, while otherwise not engaging the examiner, at least in cases of catatonia. Because it can also occur normally in individuals who are not catatonic, in small children, for example, and the elderly, especially individuals with dementia or or Parkinson's disease. So it's only a normal finding in infants and very young children. One of the cardinal features of Parkinson's disease is muscular rigidity, lead pipe rigidity, which is different. Gegenhalten is a primitive reflex that occurs naturally in newborns and some children, but then subsides as the frontal lobe develops. When there's damage to the frontal lobe, this reflex resurfaces. Neurologists consider it a form of paratonia, or abnormal tone, a subtype of hypertonia. So not just hypertonia, not just rigidity, like the lead pipe rigidity that we see in Parkinson's disease, but a curious, automatic, oppositional paratonia. The opposite of Gegenhalten, by the way, is Mitgehen, which in German means to go along with, what neurologists call a facilitatory paratonia, as opposed to oppositional paratonia, where the patient involuntarily assists with passive movement, wherein the slightest touch from an examiner can move a patient's body. Another classic textbook posturing symptom, perhaps the most famous, is also the most rarest, is also the rarest in my opinion. It's also the opposite of resistance, called waxy flexibility. But despite the fact that all medical students learn about it, it must be really uncommon because I've never seen it in all of my years of practice, and I spent many years in various hospital settings. Catatonia in general is infrequently diagnosed in my experience, despite the fact that a recent 2018 meta-analysis estimated a prevalence of nearly 10% among inpatient populations. Regardless, I've scarcely diagnosed it, and in particular, I've never seen waxy flexibility, which is where the patient allows the examiner to manipulate their limbs, raising and repositioning them, and without acknowledging the examiner in any way, the patient adopts the new pose and remains frozen in that pose until their limbs are rearranged once again. Even if an arm is raised high in the air, a patient exhibiting waxy flexibility would tend to leave the arm raised. Catalepsy can also be seen. This is muscular rigidity and fixity of posture despite external stimuli as well, but there's also decreased sensitivity to pain. Mutism speaks for itself, pun intended. The other form of catatonia is characterized by excitation, disorientation, grossly disorganized behavior, agitation, and confusion, and often perceptual disturbances, illusions, and hallucinations. It's probably underdiagnosed because it's not recognized. We tend to think of catatonia as the mute, negativistic form, but like delirium, catatonia can be agitated. There's an agitated form. In fact, delirium would be in the differential and would need to be ruled out, and is far more common than excitatory catatonia due to psychosis or some neurologic functional impairment. You also frequently see hallucinosis in delirium, but whereas in delirium there's a clouded and fluctuating sensorium in which the patient is disoriented, sometimes to place and situation as well as to the day and time, in catatonia the sensorium is clear. Despite what we call a stupor, there's no evidence of obtundation. The patient is wide awake, eyes open, looking around, possibly, or sometimes staring fixedly, but is simply not engaging, either not speaking or responding in the negative form or not making sense in the boisterous, agitated form. And their level of alertness doesn't fluctuate. They're not coming in and out of full consciousness like we see in delirium. Delirium, which can be caused by any number of medical problems, including intoxication, infections, febrile states, metabolic disturbances, etc. Ruling out delirium would involve noting the patient's temperature. The presence of a fever would favor a diagnosis of delirium over catatonia. Performing a urinalysis, especially in the elderly, who can quite easily become disoriented and agitated with a simple urinary tract infection. Performing a urine toxicology screen, a drug screen, to rule out substance-induced delirium, either due to acute intoxication or withdrawal, and doing blood work, electrolytes, serum glucose, liver and kidney function tests, etc. Catatonic individuals are not febrile, at least not due to their catatonia. Their labs are normal, their lungs are clear. They're just very much out of touch with reality and possibly hallucinating. When there is speech, it is disordered. What do we mean by that? Disordered speech. One example is a phenomenon known as echolalia, where the patient repeats the examiner's words. So, for example, the doctor asks, "Hello, Mr. Jones, how are you doing? How are you doing today?" And the patient retorts, "Doing today." That's echolalia. It's involuntary. It is indicative of major malfunction neurologically. When the patient copies the movements of others, that's known as echopraxia, and that can also be seen in catatonia. So the patient will be mirroring the doctor's gestures. Palilalia is where the speaker involuntarily repeats words, phrases, or sentences all on their own. They're not echoing anything, they're not parroting anything that they're hearing. And sometimes they're repeating mere syllables. La 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 la. You can hear really weird and not making any sense at all. So those are some examples of disordered speech. And if you see echolalia, palilalia, or echopraxia, either there's a neurological problem or the patient is psychotic and catatonic, or both. It's interesting that most of the behavior of a catatonic individual is characterized as involuntary. Certainly when a person moves their skeletal muscles, though, which are muscles under voluntary control, something in their central nervous system is directing that movement, and yet the behavior is quite automatic and beyond the understanding of these individuals themselves. I've interviewed patients after they've emerged from catatonic states, but in asking them what they were thinking or feeling or why they behaved in certain ways and why they weren't responding, they're at a complete loss, unable to explain the behavior because the question of why is actually misguided. There is no why. There is no logical, rational explanation for psychotic behavior. It would be like trying to explain a bizarre dream that you barely remember and couldn't articulate what happened if you tried, much less make sense of it and uncover motives. When patients recover from acute psychotic episodes characterized by catatonia, they're in a completely different state of mind. Patients dimly remember their psychotic episodes anyway. I've yet to debrief a patient and receive satisfying answers to those types of questions, so I've just learned to stop asking. The patients don't know why they did what they did. They can't explain it. They can barely conceive it. Catatonic patients sometimes exhibit frontal release signs, neurological soft signs, so-called because they indicate neurologic dysfunction, but they're nonspecific. Any number of conditions could cause them. They consist of a group of infantile reflexes, such as the grasp reflex, that are considered abnormal in adults. If you graze a baby's palm with your finger, the baby will reflexively close its hand around the finger and hold on to it. And the evolutionary significance of that and the sucking reflex are obvious. But those reflexes disappear in childhood, inhibited by the developing frontal lobe, which is responsible for executive functioning, such as inhibiting behaviors, including reflexes, as well as more complex behavior, including instincts and volitional behavior. And so when there's frontal lobe damage, these reflexes can become suddenly disinhibited, hence frontal release signs. Patients with frontal lobe damage due to head trauma or patients with dementia that involves the entire brain, including the frontal lobes, exhibit impulsivity in behavior and speech and inappropriate disinhibited behaviors such as aggression or inappropriate sexual behaviors. Another classic example of a frontal release sign is what's known as a positive glabellar tap, which is elicited by lightly tapping the glabrous, i.e. hairless, patch of skin between the eyebrows, the glabella. It's called the glabellar tap. And you tap it lightly to elicit the blink reflex. After the first few blinks, adults habituate to the stimulus and stop blinking. But infants are known to continue blinking, and that's normal. Their brains haven't developed enough to suppress that reflex. But when you see a positive glabellar tap in an adult, it's a sign of frontal release, meaning the frontal lobe is no longer inhibiting that reflex. And so we call these resurgent reflexes frontal release signs. When neurologists see a positive glabellar tap, for example, in patients with Parkinson's disease, they call it Meyerson's sign. Another possible feature of catatonia is ambitendency, the tendency to act in opposing ways, in opposite ways, ambi meaning both. In catatonia, ambitendency is a pattern of indecisive, hesitant, or contradictory movements and behaviors. And so the patient will alternate between cooperation and resistance to instructions, between answering questions and mutism. And so here you might see speech latency, latency of speech in patients who are not entirely mute, but it takes the patient a very long time to answer the question. They appear not to want to answer, but just as the examiner finally gives up and begins moving on to the next consideration, perhaps starts to walk away, the patient suddenly answers, often with a single monosyllabic word. Yes, no, and then the examiner returns and engages again and they get silence. But these patients don't ultimately engage the examiner in any meaningful dialogue. There are various ways of classifying catatonia. The DSM-5 lists catatonia associated with another mental disorder, which it considers a specifier. For example, bipolar disorder, most recent episode manic, severe with psychotic features with catatonia. So when it's due to another mental disorder, it's not its own disorder, it's just a specifier. It's a feature of that other condition. There used to be a subtype of schizophrenia called catatonic type, back when we still described types of schizophrenia. We had like a paranoid type, a disorganized type, etc. But schizophrenia is a syndrome anyway. And so saying paranoid schizophrenia as opposed to hebephrenic schizophrenia, that wasn't saying anything. It wasn't telling you anything. It was absolutely useless. So it makes sense that we did away with all that. And now you just have schizophrenia, but you could say schizophrenia with catatonia. You could have catatonia there as a specifier. That's the modern way of classifying that disease. It's actually more commonly seen in mood disorders than schizophrenia. Plus, there are all those other medical etiologies. We can also diagnose catatonic disorder due to another medical condition when we rule out delirium and find that, quote, there is evidence from the history, physical examination, or laboratory findings that the disturbance is the direct pathophysiological consequence of another medical condition. And so catatonia, even in catatonic disorder, it's due to some other condition. When we see catatonia, we know there's something wrong, either neurologically or psychiatrically, but it's not its own disease. It's not its own syndrome. It is a symptom. And then there's unspecified catatonia, the catch-all wastebasket diagnosis, when perhaps not all diagnostic criteria are met or the associated disorder is unknown, and you can just simply say there's some disorder and catatonia is present. True catatonia is non-volitional. Patients are not really choosing to be mute or stiff, no more than they're choosing to be agitated in that form, no more than they're choosing to be psychotic. That's one reason they can't rationalize their choices once they recover. How can they explain choices they don't remember making? Particularly bizarre ones, like repeating everything the examiner says. That's involuntary. Catatonia is a prominent feature of the post-ictal state as well, following seizure, a grand mal seizure, for example. And then you have petit mal epilepsy, which is a group of disorders that also comprises episodes of sudden detachment during a seizure. So the patient is not responding while they're having the seizure. They're not on the floor convulsing, but they're having a seizure, and so they're maybe hallucinating or they're experiencing a depersonalization, derealization, but they're catatonic just for that period of time that they're having the seizure. I have to share my personal history here. I was catatonic. I've been catatonic twice, actually. And the first time was following a seizure. I had a grand mal seizure, and in the post-ictal state, it took me a while looking back to piece it together and figure out that I'd had a seizure, but my husband heard me thrashing, got out of bed, saw me next to the bed. I was on the floor. And I remember looking up at him, and I remember him talking to me. And he was obviously asking, "Are you okay? Are you okay?" You know, calling my name. And I was looking up at him, and I was wide awake. And I knew, looking back, I can tell you that I knew who it was, and I knew that he was talking to me, but it didn't occur to me to respond. I was catatonic. I had not a thought in my head. It's one of 2 times that I've been conscious and not been thinking something, because I wasn't even thinking, oh, there's Stam. Oh, and he's talking to me. Oh, and maybe he wants me to answer him. You know, I was perfectly calm. I mean, dead still, no emotion. And I think it must be like what people who meditate and who try to achieve that state of Zen is, because it was, I had no thoughts, I had no motives, I had no concerns. And eventually I snapped out of it a few minutes later when he said something, and it kind of snapped me out of it. And then hours and hours later, I was able to go back and realize I had had a seizure. And so that I experienced catatonia in that context. And then there was another time that was really a part of delirium. So actually the diagnosis would not be catatonia due to another medical condition. It was actually delirium. And I had been up all night, I was moving, and I stayed up all night, didn't get any sleep, so I was sleep deprived. It was not during my sober period. I'm sober now from drugs. I was absolutely alert, but when the mover came to me and said, "Okay, ready to go?" And I just looked up at him. I just looked up at him and just kept looking around. He left. And then when I came to, when I came out of that state, they were gone. And I was frantically trying to piece together, okay, what's going on? Oh yeah, well, we're moving. Okay, what? I couldn't remember what the context was. It was terrible, terrible, terrible. And anyway, so I don't know if I'm going to edit this out, but yeah, those were 2 times that I was catatonic and lived to tell about it. Now, catatonia in the context of psychosis is different, because there's a theory about that, a theory that I favor, which has to do with fear. And so what is the evolutionary significance of this behavior? Often when we see a maladaptive but nonetheless universal behavior, I mean, it's something that's programmed into us, it represents an instinct gone awry. And one theory is that it's part of the fight or flight or freeze phenomenon. Most people have heard of the fight or flight phenomenon, when you have a sympathetic discharge, there's a danger, and you have to either run for the hills or defend yourself, get ready to fight. But it's actually fight or flight or freeze. Some animals freeze. Think opossums or deer in the headlights. So playing dead, which is also called a death feign, is a passive defense against predators' motion tracking when the prey cannot outrun the predator. It's possibly due to hyperactivation of the amygdala's fear circuits in the limbic system, a more primitive part of the brain. Freezing occurs when there's 100% chance that moving will lead to peril. When there's just no way that you're going to escape your predator, intense fear motivating that freeze response, that explains the efficacy of benzodiazepines. Because the treatment of choice is intramuscular or intravenous benzodiazepine, Ativan classically, which is effective in 2/3 of acute cases. You give that medication and the patients they stop posturing, they go sit down and finish their lunch, and even start answering the doctor's questions again. Until, if they're going to lapse back into it, they might lapse back into it. You might have to give several rounds to break them. And then treat the psychosis so that the cause of the catatonia is no longer there. So you no longer have an acute psychotic episode for whatever reason, major mood episode or schizophrenia exacerbation or whatever. When you no longer have the reason for the psychosis, then you're not going to have catatonia as a feature of the psychosis. But the other classic treatment that is 90% effective is ECT, electroconvulsive therapy. But that's difficult because it's almost impossible to obtain informed consent from a patient who's catatonic. Really, by definition, you can't get an informed consent. And advanced directives can be helpful, but in many jurisdictions, ECT has been carved out of that. The lawmakers are not clinicians, and they don't understand the science. They say everything but ECT. When you're conscious and lucid and not psychotic and doing well, you can consent for all kinds of treatments, medical treatments ahead of time, just in case you become incapacitated, but not ECT. Or else, if you do get an order for ECT, it's ignored. You go to a center where they do ECT and they won't take it. If the patient won't sign a consent right there or verbalize that they consent, they ignore it a lot of times. So it's hard to get ECT. But what's important is early detection. That's vital. And of course, ruling out delirium, ruling out other causes that could be life-threatening, and then hydration and other support. Catatonia can be lethal if the patient isn't eating or drinking or sleeping. Anyway, thank you. That is Catatonia. Comments,